Hi everyone, welcome back to the channel. Today we're going to walk through how to interpret an arterial blood gas, or ABG. It's a blood test that measures the level of pH, PaCO2, which is the partial pressure of carbon dioxide, PaO2, the partial pressure of oxygen, bicarbonate, and oxygen saturation. It gives us critical information about a patient's acid-base status and oxygenation. In this video, we'll be focusing on the acid-base interpretation. Let's break it down step by step. Before we jump into ABG interpretation, let's take a quick moment to understand how our body maintains acid-base balance. Our body tries to keep pH within a very narrow range, typically between 7.35 and 7.45, and it does this primarily through the bicarbonate buffer system. In this system, carbon dioxide combines with water to form carbonic acid, which in turn breaks down into hydrogen ions and bicarbonate. This reaction is completely reversible, so the body can shift it back and forth to raise or lower the pH as needed. Two systems regulate this balance. The lungs respond quickly by changing the breathing rate to adjust carbon dioxide, which increases the concentration of hydrogen ion, lowering the pH. The kidneys, on the other hand, respond slowly by adjusting how much bicarbonate they absorb or excrete. Bicarbonate lowers the concentration of hydrogen ion, raising the pH. Now let's dive into the step-by-step guide to ABG interpretation. First, look at the pH, which normally ranges from 7.35 to 7.45. A pH less than 7.35 means acidemia, while a pH greater than 7.45 means alkalemia. This gives us the overall direction of the disturbance. Next, look at the concentration of bicarbonate and partial pressure of carbon dioxide to determine the primary disorder. Bicarbonate normally ranges from 22 to 28 millimoles per liter, whereas the partial pressure of carbon dioxide normally ranges from 35 to 45 millimeters of mercury. If the pH is low and bicarbonate is decreased, that suggests metabolic acidosis, in which the body has lost base or gained acid. If the pH is low and the partial pressure of carbon dioxide is elevated, that points to respiratory acidosis, in which the lungs are retaining too much carbon dioxide. If the pH is high and bicarbonate is elevated, it indicates metabolic alkalosis, where there's too much base in the system. Finally, if the pH is high and partial pressure of carbon dioxide is decreased, it points to respiratory alkalosis, in which the patient is blowing off too much carbon dioxide. The abnormal value that matches the direction of the pH is usually the primary disorder. Once you've identified the primary disorder, the next step is to see if the body is trying to compensate for it. For metabolic acidosis, the lungs could compensate by lowering the partial pressure of carbon dioxide. The expected PCO2 can be estimated by the formula 1.5 times the bicarbonate level plus 8, within the margin of plus or minus 2, or roughly the last two digits of the pH. For metabolic alkalosis, the lungs could compensate by increasing PCO2. The expected value is roughly 0.7 times the bicarbonate level plus 20, within the margin of plus or minus 5. For respiratory disorders, we check how the kidneys are compensating by adjusting bicarbonate. In acute respiratory acidosis, bicarbonate increases by about 1 for every 10 millimeters of mercury increase in PCO2. In chronic respiratory acidosis, the kidneys have had more time, so bicarbonate increases by about 3.5 for every 10 millimeters of mercury rise in PCO2. In acute respiratory alkalosis, bicarbonate drops by about 2 for every 10 millimeters of mercury decrease in PCO2. Whereas in chronic respiratory alkalosis, bicarbonate drops even more, about 5 for every 10 millimeters of mercury decrease. If the compensation is within expected range, it's a simple disorder. But if the compensation is more or less than expected, it may be a mixed acid-base disorder. If you've identified a metabolic acidosis, the next step is to calculate the anion gap, which helps us figure out why the acidosis is happening. The formula of anion gap is the concentration of sodium minus the concentration of chloride plus bicarbonate. A normal anion gap is typically between 8 and 12. If the anion gap is greater than 16, it's called a high anion gap metabolic acidosis, or HAGMA. This means there are unmeasured acids in the blood. You can remember the causes using the mnemonic mud piles. M is for methanol, which gets metabolized into formic acid, a toxic acid that can cause vision loss and acidosis. U is for uremia, seeing an advanced kidney failure where the body can't excrete acid effectively. D is for diabetic ketoacidosis or DKA. In the absence of insulin, the body can't use glucose for energy, so it starts breaking down fat instead, leading to the production of ketone bodies, which are acidic. P is for propylene glycol, a solvent found in medication and antifreeze, which is metabolized to lactic acid. I is for isoniazid or iron overdose. Both can cause lactic acidosis and metabolic disruption. L is for lactic acidosis due to tissue hypoperfusion or hypoxia, leading to anaerobic metabolism. E is for ethylene glycol found in antifreeze. It's metabolized into oxalic acid, which damages kidneys and lowers pH. And finally, S is for salicylates, like aspirin, which causes a mixed respiratory alkalosis and metabolic acidosis. On the other hand, if the anion gap is normal but the patient still has metabolic acidosis, we call it a normal anion gap metabolic acidosis or NAGMA. In these cases, the loss of bicarbonate is usually balanced by a rise in chloride. You can remember the causes using the mnemonic hard AS. H is for hyperalimentation, where parenteral nutrition or high-protein feeds can increase acid load and lead to bicarbonate loss. A is for acetazolamide, a diuretic that causes the kidneys to lose bicarbonate by blocking carbonic anhydrase. R is for renal tubular acidosis, where the kidneys fail to reabsorb bicarbonate or excrete acid properly. D is for diarrhea, which causes direct loss of bicarbonate from the lower GI tract. A is for ammonium chloride, a substance that adds hydrogen ions to the blood and lowers pH. The first S is for spironolactone, a potassium-sparing diuretic that can impair acid secretion and lead to acidosis. And the second S is for saline infusion, especially in large volumes, which can dilute bicarbonate and cause a hyperchloremic acidosis. If you've identified a high anion gap metabolic acidosis, you can go one step further and calculate the delta gap to check whether there's a second acid-base disorder happening at the same time. The delta gap is calculated by delta Ag divided by delta bicarbonate, which means measured anion gap minus 12 divided by 24 minus the measured bicarbonate. If the delta gap is less than 0.4, this suggests a pure normal anion gap metabolic acidosis, meaning there's no excess unmeasured acid. If the delta gap is between 0.4 and 0.8, this suggests a combined high anion gap and normal anion gap metabolic acidosis. If the delta gap is between 0.8 and 2.0, this is considered normal and consistent with pure high anion gap metabolic acidosis. And if the delta gap is greater than 2.0, bicarbonate hasn't fallen as much as expected, which suggests a coexisting metabolic alkalosis on top of the high anion gap acidosis. Patients with metabolic acidosis may present with a range of symptoms, depending on how severe the acidosis is and how quickly it develops. One of the most classic signs is Cosmo breathing. That's deep, rapid breathing. It's the body's way of trying to blow off carbon dioxide to compensate for the acid buildup. Other common symptoms include fatigue, nausea or vomiting, and altered mental status like confusion, drowsiness, or even coma. Now that we've covered metabolic acidosis, let's go through the other primary disorders. Metabolic alkalosis occurs when there's an elevated bicarbonate level, which raises the blood pH above 7.45. We divide metabolic alkalosis into two major types. Saline-responsive metabolic alkalosis is marked by urine chloride of less than 25 and typically improves with normal saline infusion. Common causes include contraction alkalosis, where there's a loss of extracellular fluid like from nausea and vomiting, diarrhea, and nasogastric tube suction. The volume contracts but bicarbonate stays behind, making the blood more alkaline. Cystic fibrosis, where the patient loses a lot of chloride through sweat, leads to volume depletion and a low chloride state, which promotes bicarbonate retention and metabolic alkalosis. On the other hand, saline-resistant metabolic alkalosis is marked by urine chloride greater than 40, and it doesn't improve with normal saline infusion. Common causes include laxative abuse, which can cause volume loss and electrolyte shifts, but often presents with paradoxically high urine chloride due to renal compensation. Hyperaldosteronism, where excess aldosterone promotes sodium retention and hydrogen and potassium loss. Liddle syndrome, a genetic disorder where the kidneys behave like there's too much aldosterone, even though actual aldosterone levels are low. Liquorized ingestion, which inhibits an enzyme that normally protects the mineralocorticoid receptor, leading to a functional state of aldosterone excess. Excess alkali intake, like too many antacid or bicarbonate supplements, can raise systemic bicarbonate levels beyond what the kidneys can clear. Bartter and Gentleman syndromes, which are inherited tubular disorders that cause renal salt wasting, leading to chronic metabolic alkalosis with high urine chloride. And finally, diuretics, especially loop diuretics and thiazides, which can cause the loss of sodium, chloride, and water. Patients with metabolic alkalosis may present with a wide range of symptoms. Because a high pH increases neuromuscular excitability, patients may experience confusion, muscle cramps, and paresthesias, a tingling or numbness sensation, especially around the mouth or in the hands and feet. You may also see hypoventilation as a compensatory response, where the body tries to retain carbon dioxide to bring the pH back down. More severe alkalosis can lead to arrhythmias, especially in the presence of hypokalemia or hypomagnesemia. Now let's take a look at respiratory acidosis, which happens when the patient is hypoventilating and the lungs can remove carbon dioxide effectively. We divide respiratory acidosis into acute and chronic forms. Common causes of acute respiratory acidosis include airway obstruction, where the upper airway is partially or completely blocked, such as from choking, swelling, or severe asthma. Respiratory failure, such as from pneumonia or pulmonary edema, where gas exchange in alveoli is impaired. Central nervous system depression, which can occur with head trauma, opioid overdose, or benzodiazepine use. Chest trauma, such as rib fractures or flail chest, can cause pain or mechanical limitations of breathing. Common causes of chronic respiratory acidosis include COPD, or chronic obstructive pulmonary disease, which damages the airways and alveoli, making it harder to exhale carbon dioxide efficiently. ILD, or interstitial lung disease, which stiffens the lungs and reduces their compliance, limiting gas exchange over time. Chronic OSA, or obstructive sleep apnea, where repeated airway collapse during sleep leads to intermittent hypoventilation and carbon dioxide retention. Kyphoscoliosis, a severe spinal deformity that restricts chest wall movement and lung expansion, reducing ventilation capacity. Neuromuscular disorders like ALS, myasthenia gravis, multiple sclerosis, and poliomyelitis, which weaken the respiratory muscles, making it harder to take deep breaths and clear carbon dioxide. And severe hypokalemia, where low potassium impairs muscle contraction, including the diaphragm and other breathing muscles. Symptoms of respiratory acidosis depend on how quickly it develops. In acute respiratory acidosis, symptoms develop quickly because the body hasn't had time to compensate. You may see confusion, lethargy, or even coma, along with sudden shortness of breath. In chronic respiratory acidosis, the kidneys retain bicarbonate to compensate, so symptoms are often mild, like fatigue, morning headaches, or daytime sleepiness. Finally, let's talk about respiratory alkalosis, which occurs when the patient hyperventilates, blowing off too much carbon dioxide. As the concentration of carbon dioxide drops, hydrogen ion concentration decreases, and the pH rises. We can also divide the causes into acute and chronic. Common causes of acute respiratory alkalosis include pain or anxiety, which can trigger rapid breathing even without underlying lung diseases. Fever or sepsis, which increases metabolism and respiratory rate. Hypoxia from conditions like pneumonia, pulmonary edema, or pulmonary embolism, which stimulates peripheral chemoreceptors to increase ventilation. Salicylic toxicity like aspirin overdose, which directly stimulates the respiratory center in the brain, causing early respiratory alkalosis. Pregnancy, which increases progesterone levels and stimulates the respiratory center and leads to mild hyperventilation. And mechanical ventilation that's set too aggressively, which can remove too much carbon dioxide if not properly adjusted. Common causes of chronic respiratory alkalosis include high altitude, which lowers ambient oxygen, triggering sustained hyperventilation to increase oxygen uptake. Liver failure, which increases central respiratory drive, though the exact mechanism is complex. Hyperthyroidism, which raises basal metabolic rate, leading to faster breathing and CO2 loss. And pontine tumors or lesions, which can disrupt the normal regulation of breathing in the brainstem, leading to chronic hyperventilation. Symptoms of acute respiratory alkalosis include dizziness, tingling sensation, and muscle cramps due to increased neuromuscular excitability. Similar to symptoms of metabolic alkalosis, in chronic respiratory alkalosis, symptoms are usually mild or absent, since the kidneys gradually compensate by excreting bicarbonate. And that's a full walkthrough of arterial blood gas interpretation. and an overview of the primary acid-base disorders. Thanks for watching, and I'll see you in the next one.